You hear me?
We
Yes.
do, yes.
Okay.
Welcome, everyone. We'll get started in a couple minutes.
So those who are not going to speak right away, if they could go on mute, and then we'll ask you to join up whenever you wish to join. So Joshua, you're going to put me on live because the only thing I see is, yeah, okay, right.
Yes, right now we're just showing our clock. Welcome, everyone. We're going to get started in about 1 minute.
يا صلاح، بقول لك ايه، روح اسمه ايه ده؟
Could the others who are not going to speak just mute themselves for the moment? Thank you.
You hear me now?
We do, if you want to get started.
Okay, I'm ready.
No, not yet.
Dr. Rob, go ahead.
No, this is me. Everyone else needs to mute up, please. Good morning, and welcome to the SCAI Bifurcation Club webinar series. This is your host, Dan Webb. Very pleased today to have our colleagues from the Middle East Bifurcation Club join us. We specifically have targeted this series to be run every third Saturday with so that we can incorporate colleagues from the Middle East and Europe to be part of this webinar series. We are very happy that the bifurcation clubs have proliferated in different parts of the world, and we will invite all of them to participate in these webinar series. So next slide, please. This is the SCAI sponsored webinar, and this has been a very successful webinar for the past year. These are the disclosures. Next, please. Our moderators today are Mirvat Al-Asnaf from Saudi Arabia and Benita Shah from New York. Panelists are Dr. Khalid Al-Shaibi from Saudi Arabia, Dr. Amir Hadidi and Dr. Habib Kamra. And the presenters today will be Dr. Al-Asnaf, Dr. Ziad Ghazal from Lebanon, and also Fadi Sabsaria from Lebanon, who present cases. Next, please. So this has been supported by Medtronic through unrestricted educational grant. Next, please. The CME credits are applicable to this program. Next, please. And you can go to my courses to get your CMEs and ABI MOC wherever applicable. So without much ado, I'll ask Mirva and Benita to get started and introduce the speakers and the panelists. And if you have anything else to add, we'll get going now. Thank you so much.
Thank you so much for having us. I'm super excited about this series and looking forward to hearing both Mirvat talk about imaging as well as seeing these two cases. Maybe we can go around and sort of introduce ourselves. I'm Benita Shah. I'm an interventional cardiologist at NYU in New York. Mirvat?
Mirvat Al-Asnaj, I'm an interventional cardiologist at King Fahd Armed Forces Hospital in Jeddah.
Dr. Al-Shaibi?
Khalid Al-Shaibi, I'm the director of the Cardiac Center at the King Fahd Armed Forces Hospital and the president of the Middle East Bifurcation Club.
Dr. Al-Hadidi?
Professor Amr Hadidi, Professor of Interventional Cardiology, President of the Egyptian Working Group of the Egyptian Society of Cardiology, and the Vice President of the Eurocity Club.
Dr. Gamra?
Habib Gamra, I'm a professor in cardiology at the University of Monastir in Tunisia.
All right, well, welcome everyone. And let's just get right into it. Dr. Al-Sanag, do you want to get us started talking about imaging and how to make it easy in these bifurcations?
Sure. So my slides are there. Can you see them?
We can.
Yes.
Perfect. So I'm going to try to make this quick. And, it's important to note that I don't have any relevant conflict of interests. I think a lot of us remember the October trial that was presented at ESC in 2023 that really set the tone for the utility of intracoronary imaging during bifurcation PCIs. And then there was a meta-analysis the same year presented by Greg Stone. But although these are the two that we often quote, at least more recently, we have to remember, and I am going to go into a bit of detail with the October trial, but we have to remember that actually there's a plethora of data out there that actually looks at the role of intracoronary imaging in improving not only acute procedural results, but also major adverse cardiovascular event rates. Whether we're talking about osteal lesions, bifurcations, calcified lesions, and so on and so forth, there's a battery of these trials, including the Renovate Complex, Ultimate, and so on. The reason I want to focus on the October trial really is because this is a trial that actually showed us step by step how operators are to be using intracoronary imaging. And the reason why is that when you actually look at the outcomes of bifurcation PCIs, from the Syntax trial, the 10-year mortality was 30% compared with 19.8% in those who did not have bifurcation lesions. And then you look at the eUltiMaster registry, again, it included over 35,000 patients. MI, target lesion revascularization, and stent thrombosis were higher in the bifurcation PCI group compared with non-bifurcation lesions. So what they did in the October trial is they took 1,200 patients who were unstable angina, stable angina, and non-ST elevation MIs, but with true bifurcation lesions. And the side branch reference diameter was 2.5 or more, and randomized them 1-to-1 OCT guided versus angiography guided. And then at 2 years, they looked at the primary endpoint of MACE that included cardiac death, ischemia-driven target lesion revascularization, and target lesion myocardial infarction. And you can see over here that they actually adopted intracoronary imaging in at least 3 different steps, but it was quite extensive. So there was an OCT that was conducted to actually look at the lesion, get the appropriate measurements, reference diameters, etc. And then during the intervention, looking at post-stent evaluation by the OCT, looking at stent apposition expansion, but also looking at wire position. And then they actually, at the end, looked at everything. Now, I'm just referring you to a publication that we did very recently where we're trying to show that intracoronary imaging actually can help you when you use OCT to see if you are abluminal or not. And the reason I actually mention it is if I refer you back to the October trial, I'm going to get to it in a couple of more slides, but it was, although these were reference centers and tertiary centers with operators with extensive experience with using intracoronary imaging, there was still a significant number of patients where they didn't recognize abluminal wiring and they had stent deformation that was detected in the core lab. So when you look at the total cohort and you look at the 1,200 patients, 600 patients allocated to, as I mentioned, OCT guidance and 600 to angio guidance, the average age was about 66, 21% were women, but you clearly see the event rate was much higher in the angio guided compared with the OCT guidance, and it was statistically significant. So really in patients with coronary bifurcation lesions, OCT-guided PCI did in fact at 2 years reduce events compared with angio guidance alone. This is the publication I'm referring you to that was earlier this year, where they actually looked at the incidence of stent deformation. And stent deformation was not negligible in this group. Oops, sorry, I have to come back. So it actually occurred in about 9.3% of the OCT-guided cases. Accidental abluminal wiring was in 44%, and guide catheter-induced deformation was in 40%. So 18.5% of all cases were left main bifurcations where this happened. Abluminal rewiring was 33 in the OCT-guided cases, that's 55.4%, corrected by physicians in 18 out of 33, which is 54.5%. So almost half of the patients were not corrected, and it was actually missed. So the 2-year MACE with untreated deformation was 23.3%, whereas patients where they did correct it, there was no events rates at follow-up of 2 years. So as you can see, I think the messaging here is that intracoronary imaging assists you in identifying not only appropriate apposition and expansion and so on, but actually in the procedure itself, assisting us in figuring out what's going on. The next is the meta-analysis that was presented by Greg Stone. Now, this was a network meta-analysis where they took several studies, and what they wanted to look at was IVUS versus angiography, OCT versus angiography, and IVUS versus OCT. But then they also looked at the overall effect of using intracoronary imaging, be it IVUS or OCT, to improve outcomes compared to angiography. And it included over 20 randomized trials, 12,000 patients with CCS and ACS, so that was a big number of patients, 7,000 randomly allocated to intravascular imaging, 5,000 to angiography, and they looked at events between 6 months and 5 years. And as you can see, these are the different trials that they actually ended up including. October was not included in this trial. The primary endpoint was target lesion failure as a composite of death, target vessel MI, and target lesion revascularization. And the secondary endpoints were these individual components. And the network of all these patients actually showed that compared with angiography-guided PCI only, intravascular imaging with OCT or IVUS reduced events by 31%. And it was driven 46%, 20%, and 29% reductions in cardiac death, target vessel MI, and target lesion revascularization, respectively. The imaging arm reduced stent thrombosis by 52%, all myocardial infarctions by 18%, and all-cause death by 25%. I mean, these are substantial numbers that I think at this point in time are uncontested and unequivocal. So the outcomes were actually similar for OCT and IVUS guidance. There was not significant difference when you looked at, remember, they looked at OCT against angio, IVUS against angio, but then they also looked OCT against IVUS, and they really were quite comparable. And this was presented by Davide Capodano during the ESC, and he actually looked at if you start adding October or Illumian to these trials and so on, you still see a significant relative risk reduction when you're using imaging compared to no imaging at all. So what this meta-analysis in particular is telling us is that whether you're using IVUS or OCT to optimize outcomes, there is an improvement in long-term prognosis of these patients. What are the implications? The routine use is going to improve long-term safety and effectiveness of these procedures, but we are going to need to weed out which lesions in particular do improve outcomes when you use intracoronary imaging. Now, the latest European Society of Cardiology guidelines that were elaborated this year, only months ago, actually really gave a 1A recommendation for the use of intracoronary imaging in complex lesions. They defined complex lesions as lesions that are long, lesions that are bifurcations, and left main. So really, those are the lesions that we should be using. And very quickly, what is it that we're doing? We're looking at MLD. In IVUS, it's pretty much the same thing, essentials 1, 2, 3, but you're really looking at morphology. You want to look at the calcium, determine and quantify calcification, high-risk plaque features, the length, You don't want to eyeball these things, stenting and stenting size. And remember, we take into consideration patient risk profile, and we want to know what are the procedural implications. Are we going to use plaque modification tools or not? And we need to identify landing zones. Post-procedure, we want to look at medial dissections, stent apposition, and stent expansion. And a lot of these new automated devices are actually going to give you an automated percentage that's going to tell you whether you are adequately apposed and expanded. And remember that ideally you want to be at least over 80%, if not 90% is actually what is recommended in terms of stent expansion. And then you want to look at distal edge dissections and so on. Edge dissections, what is actionable? Not everyone is actionable. What you do want to look at is a significant dissection that reaches the intima, that is longer than 2. And you know, there are different definitions depending on which you use. But generally speaking, this is what you want to see if it's longer than 2 millimeters, deeper and reaching the intima. But bear in mind, a lot of the data that we have about malapposition in particular and edge dissections are a little skewed and biased because they were actually in patients in whom we had events. And so we went back and looked, a lot of these studies actually went back and looked at the intracoronary imaging, and it's not really sort of all-comer cases. I want to focus very quickly in the last couple of minutes with left main disease. And I know I focused a lot on OCT, but you know, IVUS is equally valuable. When you look at this distal left main, it is a Medina 111. So the distal left main is included ostial LAD, ostial circumflex. Not only is the left main an important vessel, but it's actually got the most variability in the anatomy of the bifurcation. You have different sizes of the assigned side branch in the main vessel. So if it's the circumflex, it could be a dominant vessel, it could be a non-dominant circ. In addition to that, there's the size discrepancy. The left main LAD and circumflex has the most variability compared with a lot of the other bifurcations. And so it is absolutely critical when we're using imaging that we use imaging that not only defines the morphology and tells us how much calcification and so on, but really to give you proper measurements that allow you to decide what tools you're going or equipment you're going to start to use. So so this is based on EEL. You see a beautiful EEL over. You see the media is very clear and nice and black, and you can go all the way along and do imaging in the left main, the circ, the LAD, and determine what your diameters are. And then post-stenting, this is exactly what you want to be doing. You want to see that you've got it covered, the ostium of the left main. You want to look at all your bifurcation. You want to be able to look at your carina. So the top image is actually the second one from the left. The top one is the carina, and you see a very nice opening into the circumflex. And you continue to look at the distal edges, whether you're looking at the LAD, the overlapped segments, and so on. And so it's very critical that we do appropriate sizing. This was the exact same patient. Novel tools that we're able to use, and I do think it's important to use them, but to use them with caution because, again, it's radiation exposure. So there's the clear stent or stent boost, and depending on which technology you're using. Lately, we have the GE that actually can give you these 3D images and actually can help with the wiring. And you can actually see, I can potentially see it helping in bifurcations in particular, so that in the process, before getting your IVUS or your OCT image, you can actually see where your wire is. And when you do these kind of enhanced imaging, you see whether you're abluminal or not. So it's something that still needs to be proven, but really something out there that is probably helpful. Thank you. And I'm going to stop here and hand over to Tanvir and Benita if you want to discuss or move on to a next case.
It's great. What a great summary of the data and use of the technology. So I'd love to go around the panel and talk a little bit. You know, I feel like left main bifurcations are its own beast, and I think there's a pretty good consensus about using imaging in both arms when we're dealing with left main bifurcation. So maybe if the panelists could tell me a little bit about the usage in non-left main bifurcations, how often your colleagues, your institution is using imaging, and if you could give just one tip to those who don't use imaging too much, what to focus on when they're using imaging in these non-left main bifurcations. We'd love to hear your take-home point. I'll start with Dr. Al-Shaibi.
Okay, well, I think Mirfat put it very nicely. I think the real utility of imaging when you're dealing with complex anatomy. So left main certainly qualifies there. And then any other complex bifurcation, I don't routinely use it all the time in a simple bifurcation lesion where there's not much disease in the side branch. But as the lesion becomes more complex, as the disease in the side branch becomes more complex, I think as the lesion is longer, where there's a lot of fluoroscopic calcium, the more complex it appears angiographically, the more benefit I think there is by using imaging to clearly define those parameters, whether it's whether or not you're going to need plaque modification tools and determining safe landing zones and proximal landing zones and sizing. So I think the more complex the anatomy appears angiographically, the greater the reason to use intracoronary imaging.
Yes, I thank you, Merit, for this great presentation. The most important thing is that you have non-left main bifurcation lesions and you have left main bifurcation lesions. Definitely, in our country, in Egypt, we don't use in every case, definitely. But in non-left main bifurcation, it depends on the size of the side branch and how it is significant to deal with, especially if you are comparing between provisional and to a stent strategy. This is very important, especially if you have a heavy calcium, you need to good sizing of the vessel. But definitely in left main, we use it more imaging, definitely, because always you have a discrepancy between the size of the left main and the two branches. So this is very important to size, especially this is covering a very big area of the myocardial interfering with a high-risk patient. So the use of imaging is very important in this case.
Dr. Gamra?
Yeah, I agree with what was just said. I mean, left main usually is the focus, and when it is a left main lesion, then we have to use imaging. But in non-left main lesions, I think proximal LAD, proximal left circumflex, should be the focus, and where we should use imaging as much as we can, because it's not widely available in Tunisia either. And stent apposition, I think that's the main concern of the operator, and that's maybe the main purpose of using imaging in that particular lesion.
Yeah, so my take-home point, and I agree with all of the comments that have been made, is that if you're not doing enough imaging, my take-home point is to just do it as much as possible, because something that Dr. Alsanov had highlighted in her talk is that you see things, but that doesn't mean you have to act on it. And you really need to put the whole story together in terms of what you're looking at intravascular imaging, what you're looking on the angiography, how does the patient look, how would you have tackled it without imaging, how does imaging change your mind? To me, that is the hardest part of imaging. I was trying to figure out what to do with the data that you've gotten. And the more you do it in simple elective cases, the more likely you are to have a better understanding of how to react in some of the more complex cases and whether to react. So that's my take-home point.
One question from Mervat. So which cell to wire on OCT imaging? I think that's a tedious process. The Japanese, so what are your views? Because the Japanese put a lot of effort into multiple OCT runs. I wish we had an OCT camera which did not require contrast clearance. Just sit there and help me wire. What is your view on that?
It's sort of towards what Benita was saying. The more you do, the more comfortable you get with the, analysis of what you're doing. And I showed you that the October trial, these were expert operators who actually missed that they were abluminal wiring in a good % of their patients. The nifty trick that I learned with OCT for bifurcations is that you do, you eliminate tissue elimination. And you sort of do what I showed you with the GE, the fluoro enhanced, and that actually helps a lot more to see whether you're abluminal or not. The tissue can be a little tricky when you have it in there. And the other thing is to remember that the more you do it, your team has to get facile with it as well, the setup, especially OCT and so on. And so it's critical that you get your team up to speed when you're doing it. I want to move on to Dr. Ghazal, perhaps, so that we can discuss it more practically through a case. And he's going to tell us a complex bifurcation case from Lebanon.
Yes, good morning or good evening, wherever you are in this part of the world. And thank you, Tanvir, for inviting us and putting all this together. And thank you, Mirvad. So I want to discuss with you this 89-year-old gentleman who has a history of DVT, dyslipidemia, hypertension, and a history of soft tissue sarcoma, received radiotherapy in the remote past. So he presented with oppressive chest discomfort at rest and with exertion. Generally, he's in good health and he's fairly functional at the age of 89. Note that his creatinine is 1.5 with an estimated GFR of 41. And he carries an ejection fraction of 45% chronically with mild global hypokinesis. So he was planned to have a cardiac catheterization, but of course we had a concern regarding his creatinine at his age. We hydrated him properly and he received the cardiac catheterization that day. And as you already see that these are calcified vessels. There's an osteal LAD and there is an osteal circ OM lesion, which is quite tight. You notice also that this osteal LAD, there is a 1 or 2 millimeter length segment prior to the tight spot, but for all practical purposes, it is an osteal LAD. And you can see it here. You see, for example, let me see if I can get my laser pointer. You see my laser pointer here?
Yeah.
Yeah. So you can see here how there's this little ectasia just prior to the tight lesion. And of course, you see here this OM bifurcation lesion. You see also the calcium in the LAD starting from the left main all the way down to the mid LAD and also the circumflex. And this is his right coronary artery. And you can see here that this is not even a very simple lesion to wire because it's sort of a lesion just before a bend. So we were expecting the wire to maybe give us some challenge. So I want to, if you don't mind, Benita and Mirva, just to bring these questions for discussion. And for example, one is revascularization strategy. The guy is 89, creatinine 1.5, fairly functional. CABG versus PCI. And if you choose PCI, what are the specific risks you should share with the patient and family? And I think that's an important question before when we do sort of ad hoc angioplasty. And if you plan on PCI, should it be staged? And if staged, which vessel would you treat first? And as you deliberate, I just want to go through, I mean, without saying anything, I just want you to see, and for the audience to see the lesions again. But go ahead and let's have some discussion.
That's great. So
Okay.
how many of you are sending
Yes.
this patient off to bypass?
Yes, bypass surgery and the age of this patient, 89, is a very old patient. I don't know if all the cerebral vessels are okay. I don't know if it is okay, and because sometimes it's very in these heavy calcified lesions that you have a problem in even the cerebral circulation and the maybe high risk to do surgery for this case. Yes, if he's younger, maybe it's a case for surgery. But the problem is that we have a very high risk osteal LAD, and I think this is our main concern now. It's a staged procedure, I think, for me. Do the left first, and then another stage for the right. But the point is how to deal with this calcium. So we need to test first the osteal LAD, because if it's balloonable or not, to define which I can do with imaging first, to assess if this can be one of the plaque modification for this calcium. And then we arrange and respond according to what we will do in the ostium, and then we can check what we will do. Because it's a very short left main, so I think that we cannot stay at the ostium of the LAD. We may cover it, but we need to decide what to do in the circumflex before doing the left main LAD.
Yeah, so, you touched on some of the needs for imaging here. For sure, the
Yes.
calcium and the assessment of the ostium of the left main to determine length and so on and so forth, but also the patient's GFR is low and perhaps you want to use as little contrast as possible. So that also will assist you in using ultra low contrast in a situation like this. So any tips and tricks on defining your landing zones without using contrast, with using imaging alone and perhaps additional wires? How would you tackle that in this LAD?
So IRIS guidance would be helpful here, where it'll help us with, low contrast. I wouldn't say completely zero contrast. But I agree with Amr that the short left main and the discrepancy in the size, the left main is a very sort of succulent left main. You look at that, and then it just very quickly becomes two small branches. Definitely wire both, protect wire both, and imaging would kind of help you determine how much calcium is in that tight osteal LAD. Habib, which strategy would you adopt? Would it be a provisional strategy? And what is your backup to stent strategy if you needed one?
Yeah, this is obviously a high-risk patient, and Dr. Amr was mentioning surgery. I completely agree, but I don't think that there's any surgeon who will be happy to operate on such a patient, 89-year-old patient. So going to the left first, obviously, I will go to the left circumflex first and make it as simple as possible, provisional stenting, obviously. Stenting, short stent with that left circumflex. And then we'll see what happened to that OM, and then focus on the osteal LAD. Now, my prediction is that the patient will need most likely a calcium modification, because it looks already a very calcified lesion, and I will use it probably in the osteal LAD, because this is going to be a left main stent, and it has to be optimal. So stenting the left circumflex, provisional, and focus on the left main LAD. It is true that this is going to be quite difficult to do because of discrepancy of diameter. But I think with imaging and trying to define the size of the left main, we will select the right stent size.
These are all very nice comments, and thank you very much. But would anybody start with the right, just to get one easier lesion out of the way, so that if we get in trouble on the left side, at least we have this very tight right opened up? Because that's what we decided to do. We decided
Actually, I was just going to say that. I mean, the right, some tortuosity there, but I think I'd give myself some leeway by treating that, which is a relatively straight, easier procedure to do, and get an optimal result there, and then bring it back for a staged procedure. And I think, as Dr. Gamra mentioned, I would start by treating the circumflex, because once you stent from the left main into the LAD, treating the circumflex then becomes more difficult, because all your equipment would have to pass through struts. So
we took your advice. And well, I'm saying we because this patient happens to be my uncle. And, nothing worse than working on a very dear family member. And so I asked my closest friend, Fadi Sawaya, to be with me on the case. And we both decided to do the right first and then staged him, as Khalid was saying. It was a bit difficult to wire that right. Finally, with the Sion Black, we were able to do it and put a let me see. Oh, yeah. So we,
I was going to
So
say
we-
nothing about this RCA is super simple. It looks calcified, tortuous.
Yeah,
and
it's not an
critical.
easy. It's not an easy. So
and we had to put this AL catheter. It took more than 100 cc of dye probably to just get down there and do what we needed to do. So I'm just showing you briefly this long stent with a good result. And to make the long story short, we decided to stage them, as Khalid was pointing out. We thought, let's see what the creatinine would do. By the next day, that creatinine of 1.5, and I see this all the time when we hydrate the patient, it came down to 1.3, and we planned for a stage procedure at a later date. What later date? And we thought to check the renal function. I need to remind you, Fadi and I live in Lebanon currently. And when we did this procedure, it was a bad day security-wise in Lebanon, and a few days later, the war started. So that next planned procedure was delayed. And so my uncle presented a month later with exertional dyspnea and mild pulmonary edema. So we put it off intentionally because of the situation in the country, but he declared himself earlier. He came back with now an ejection fraction from 45% down to 25%. He had enteroapical akinesis, total akinesis. His creatinine now is 1.9. He left the hospital at 1.3, GFR 31. Troponin was elevated. There was no acute event. So he just came, he said, I've been feeling short of breath for the last few days at rest. And there was no acute changes. This is his EKG, which shows an incomplete left bundle, first degree. And you see there are some R-wave progression. So now we have him in the emergency room. The question is to you guys, why was there a significant drop in the EF? Do you think that the LAD closed in the interim? Now, remember, there was no acute event, so I don't think he had a STEMI, but if it closed, was it collateralized? And why is there a significant rise in the creatinine? Is it all contrast-induced nephropathy? And what would you do now?
Yeah, these are great questions. I mean, it sounds like it didn't present acutely, so I would think anything, a little bit of high blood pressure, a little bit of a fast heart rate, a lot of stress going on externally, anything could really, in the setting of a critical lesion, exacerbate and create an type 2 STEMI that results in a significant drop, especially when the lesion from the beginning was supplies a huge territory and is severe to begin with. So it may not have closed. It may still be very similar, but just the stressors on top of a lot of atherosclerosis can certainly lead to it. What we worry about with the significant rise in creatinine is, what is his cardiac index now doing? Is he perfusing well enough? And now you have not just an anatomically high risk patient, but also potentially a hemodynamically high-risk patient, and that adds a whole other factor there. Any other comments?
Yes, I think that okay.
Yeah, go ahead.
Go. So the point is, this is my my concern from the start. You have a critical LAD, which is in circumflex. Both are supplying most of the myocardium. And the point is, whatever it is closed or reopened again, and after, because there is in the ECG, you have a QF from V1 to V3. It looks to me in the ECG, I don't know. Okay. And with, the point is, this patient, to me, I would like to start with because now we have creatinine as rising, and then we have to deal with this patient because we need to know what happened. So we need to prepare these patients with nephrologists to assess what to do, but we need to do an angiogram again, IVUS imaging, and to see what's happening, because the RCA, it was stable. I know it's critical, but the problem is the haziness and calcium in the LAD. I think this is we need to tackle to assess and what to do and to improve the LV function.
Yeah,
So-
to be contrarian, if it's just one vessel I could have to do in this case, that will affect longevity and prevent heart failure. I know there's multi-vessel disease. I always go after the LAD because that's what gives you
Same.
survival and decreases chances of a cardiac event or heart failure. And I probably, if I were doing this case, I'll probably go for the LAD first, just because I want to make sure he's got longevity. But that gives you survival. That's my opinion.
I agree with that. I would have done the same. There's a question in the chat in terms of IVUS versus OCT, and which modality would you use? I think OCT comes with contrast, and you can't with IVUS, you want to do a pullback to try to get some exact length measurements as much as possible. Look at the bifurcation along the way, and you can minimize contrast with IVUS. So I agree with your use of IVUS here as well. So what happened?
I'm just gonna go ahead just to only because we only have a couple minutes left. So we discussed it with the family. Now he has an EF of 25%, rising creatinine. And if we were to do the complex LAD and circ marginal lesions calcified, it carries a significant procedural and renal risk. So we decided with the family, and I was part of the family, to try to optimize him medically and see if he can improve before we address his other lesions. He did well on diuresis in the hospital, and he was discharged 4 days in a stable condition, feeling much better on home diuresis, but he was readmitted 3 days later with chest pain, dyspnea, and at this time, he definitely had desaturation. His creatinine was 2.2. That was 4 days later, so definitely he didn't like conservative management. And at that time, I took him to the cath lab. Fadi was already across town, so I was on my own. And I told my cousins that we could be facing dialysis because I wasn't expecting, I was expecting things to be a bit complex. And this is how it looked. That LAD was still open, but very, very tight. And you see how there is this, I would say it takes off eccentrically. You see this circ marginal lesion here. It takes off a bit eccentrically in a bit of an ectatic area here, very short beyond the left main. So if you look at it here on a magnified view, the reason why I'm pointing this out is because I had a very hard time wiring it. I wanted to wire that LAD first. I knew the circ wiring wouldn't be too much of an issue. Remember how it looked, and remember the calcium. So here the question is, but I'm going to just zoom through it. Should we use a calcium modification tool? How should we approach the calcified osteal LAD? And I think in the discussion prior to this, you guys already have elaborated on that and whether we should cover the left main or not. Whether we should place an osteal stent in the LAD versus a left main stent to the LAD, and then what's the approach to bifurcating marginal to stent technique versus provisional. So let me tell you quickly what I did. The common approach that was nicely discussed during this session is intravascular imaging, and I think Mervat really elaborated very maynicely during her presentation, and of course, calcium modification technique. I didn't use any of the two, and I want to maybe use the excuse of the Eclipse trial, which just came out probably around the same time. Orbital atherectomy versus conventional balloon angioplasty prior to DES in patients who have de novo lesions with severe calcium, just like this patient, identified by angiogram or intravascular imaging. This was, as you know, recently released at TCT. In fact, intravascular imaging with these very severely calcified lesions was performed in only 62% in each group. And the conclusion was that the routine use of orbital atherectomy did not improve minimal stent area or reduce target vessel failure at 1 year compared with conventional balloon angioplasty prior to implantation of the drug-eluting stent in severely calcified lesions. Anyway, I had a very hard time wiring that LAD. And you can see I ended up landing in tiny little branches. And if once I was pointing in the right direction, the wire was buckle. Use several guiders to try to orient me better, probably 5 different shape guiders. Even going back to a JL, finally decided to do that circ, which actually turned out to be very easy. Ballooned both branches, provisionally stented it, looked good. Went back to the LAD, of course, with microcatheter. And we have to remember, when you use a microcatheter in such an ostial, very tight eccentric lesion, you could close it completely. And you can't say if you're not careful, because I'm not sure how we can be careful or not careful. But
Which wire?
Which way? What?
Wire. Which wire to use?
Yeah. So yeah. Started with regular wire like the run through, then the whisper, and then Xeon blue, Xeon black. Finally, what worked was I really wedged the microcatheter as much as I could carefully in a position at an angle where I thought it would be the place to take off, and then with a Gaia 1 wire. So that's what basically used. What worked with an EBU 4.5. So you have to remember all of this took quite a bit of dye, changing catheters, and obviously on the table, you start getting a bit the snake pressure. We started off with 100, 110. We were a bit down to in the 90s, but finally we were able to wire it, ballooned it. And then after all of this, I decided to place the stent ostially. So forget here about imaging, calcium modification. This is a, your regular multi-vessel disease patient who's progressing in the way that I described. It's not a stable patient sitting live to be performed live in a big conference. And we don't have the luxury here to use imaging. Of course, we have IVUS and I can easily use it. But I thought with everything that went on, I just wanted to finally get out. So we placed it ostially, and basically it started looking good, a little bit of post-dilatation. And you can see here how the stent was actually, luckily, very nicely placed at the ostium. By the time we were finishing, he was needing to be on BiPAP, so I didn't want to put an IVUS into that lesion. I accepted the final outcome, which was angiographically very good. You see that lesion in the circ and here in the ostial LAD that were nicely opened. The creatinine, when he was, before that case, was 2.2. I kept him in the hospital a few days watching his creatinine rising all the way to 6.45. And we were almost going to start dialysis, but then it came down. I think it came down not because, one of the reasons in this cardiorenal syndrome is that when we repeated his echo 4 days after the procedure, his EF went up from 25% to 45%. And as Benita was mentioning, maybe his creatinine initially went up also because of the drop of the EF and low perfusion. And now everything improved after we totally revascularized him. The LAD, which was the wall, which was akinetic, came back into action. EF improved, perfusion improved. And then actually 2 weeks ago, his creatinine was 1.3 last time we checked it. So he was back to his baseline or even a little bit better.
I think amazing case. Amazing case.
Yes.
That really was, and great save. And I'm glad he's doing better. For the sake of time, we're going to move on to the next case for Dr. Sawaya. I will, while he's loading up his slides, I will mention those large left mains where the wires are buckling. They can be incredibly tiresome and frustrating to deal with. One easy trick that sometimes like maybe has worked for me about 80% of the time is putting that second wire in the circumflex and putting a balloon over that second wire. And then when you're trying to take that first primary wire into the LAD, instead of buckling so much, it bounces off of the balloon shaft that's in the circumflex, allowing you to have a little bit more directionality in the LED.
Yeah,
It doesn't work all the
unfortunately-
time, but sometimes it does.
Unfortunately, it was buckling the other way. So here in
Yeah.
that, but this is a good good tip
Yeah.
in a specific situation.
Very, very good case. The use of CTO techniques in non-CTO lesions. It's very nice to have this great case. Thank you, Dr. Ziad.
All right, Dr. Sawaya.
Fadi, you muted.
Yeah, it's fine. I figured it out. I was saying, sorry, Ziad, I left you in the second part of the case.
Yes, you always do that.
So this case is an 84-year-old female who came to our ER with chest pain, shortness of breath. It's been going on for a few days, and she came to the ER. She had a medical history of hypertension, a new diagnosis of severe aortic stenosis with a valve area of 0.9, mean gradient of 36. That was diagnosed actually at the time of the ER visit. She had a preserved ejection fraction and had other comorbidities. Let's see. Why it's not moving. Okay, so the EKG, you can see it here. You can see some ST depressions in the anterior leads, V4, V5, V6, some maybe ST elevation in V1, V2. Not benign looking EKG. So of course we took her to the cath lab, and elderly lady, very tortuous brachiocephalic artery. First image, I directly went with the guide. Actually, I had shot the right, I'll show it later, but directly went for a guide for the left. You can see this is the first image, REO caudal. It looks like we have a distal left main lesion. And then this is the cranial view. You see you have a Medina 1-1 with a 99 at distal left main, 99 ostial LAD, 99 ostial circ, and this is the spider view. Patient was quite unstable on the table. She had marginal blood pressure, and this is the right coronary, which was free of significant disease. So if we look at this case, we have an 84-year-old lady, multiple comorbidities coming with acute coronary syndrome. She has severe aortic stenosis, and she has this Medina 1-1 configuration with the distal left main. So discussion, I think, that should be talked. Should we send this patient for surgical AVR and bypass? Should we do a TAVR and PCI? If we decide to do a TAVR, should we do the PCI before, during, or after? Which strategy of stenting, 2 stent versus 1 stent? If we decide for a 2 stent technique, which technique in your opinion, would be the best? Would you use lesion modification? And which lesion modification? Would you go for atherectomy? You go for shockwave? And of course, imaging should be used. And would you use hemodynamic support? I think this is where we can start our discussion.
All great questions. Do you have additional data before we get into the panel discussion, just in terms of the any parameters on echo or right heart cath to indicate the stroke volume index or cardiac index, or what his blood pressure is, pulse pressure, heart rate?
Yeah, so her LTO-TVTI was normal. Her blood pressure was like 100, 110. She did not have any other valvular lesions. Her PA pressure was around 45. And we did not do
aortic valves?
Yeah, aortic valve was 0.9 and mean gradient 36.
That's helpful. So, group, what would you do?
It's a very high risk procedure. Definitely, I have a severe aortic stenosis, and then the valve is bicuspid or tricuspid?
Tricuspid.
Tricuspid valve. So there is a lot of discussion about to do PCI first or TAVR first. So I think this is a very high-risk procedure. You need to be ready for both. For me, I will do both in the same session. I will do be prepared, and then we'll do first the left main bifurcation, and I think we test with the balloon if it's okay. You can imaging to assess if you need a lesion modification or calcium modification, whatever you see during imaging. And then this is I think it must be very fast to cover the coronary problem, and then go for TAVR at the same session.
Yeah, so for me, this is a case about planning and understanding what all of your bailout approaches are. So obviously, you know, we can stop and discuss and determine a great strategy, but for the sake of time, if we presume we're going for a TAVR PCI route, you know, I want to know what the peripheral anatomy looks like. I want to know what I can do should the patient require atherectomy. I mean, we just saw a great case where everyone said she's going to need rota, and it turns out the non-compliant balloons were enough to fully expand without calcium modification. So, you know, just because it looks severely calcified on angiography, imaging can help us determine whether or not we'd really need anything more than a non-compliant balloon, or we're going to need something more. So until we have more information, we're getting started. If you're trying to minimize the risk, and if you cannot do both in one setting, you know, I would just want to know what all of my backup options are. Should balloons go up and the patient's blood pressure is tolerating it, that's great. Otherwise, depending on the right heart cath numbers as well, what the wedge is, what the index is, if there's any borderline lesions and I'm going up on balloon simultaneously in the LAD and circumflex, then I would have a lower threshold to consider BAB with hemodynamic support. But again, only if all the parameters suggest they're higher risk and or potentially needing atherectomy. Any other thoughts in terms of?
I think, I mean, here we need to think about the whole patient. So I'd like to know, is her presentation, I know she came with oppressive chest pain, but was it an ACS? Did she have a troponin rise? Or is this demand type, which is an ACS? So in that situation, you're sort of obliged to you have an unstable plaque, and I think that answers the question. So you're going to probably need to deal with the coronaries. The other question, were you able to get a CT to assess her aortic valve as far as the root anatomy, left main annulus distance? How easy would it be to reaccess? No, you didn't.
I had none of this information. She came as a transfer to the ER and from the ER to the cath lab. Like I had no information.
Yeah. So I mean, if it's an ACS, so you're talking about an unstable plaque, I think you're obliged to treat the coronary. But maybe one thing you could do would be something like a balloon valvuloplasty, and then proceed with the PCI, just to give yourself some room in case the blood pressure drops. Or even impella support, a balloon valvuloplasty and impella, and then proceed with treating the left main, the complex left main.
Is the patient having ongoing chest pain during this time, or is she?
He came in for like chest pain. Like his main presentation was chest pain. He had dyspnea, but he came into the ER just because he was having ongoing chest pain.
And still having chest pain on the table, so you're feeling like
yes. And if you look at the EKG, like he had like dynamic changes.
He was stable at the admission, because I thought that the patient is not stable.
No. I mean, he having chest pain, like ongoing chest pain.
Only chest pain.
Yeah.
Okay.
May I have a comment? I think the debate when you have coronary artery disease and aortic stenosis, which one to start with, the debate is still open. And in this particular patient, because the patient is coming for acute coronary syndrome, I don't think that we have a choice. We have to treat the coronaries first. Now, as for the previous patient, this patient is quite old and certainly highest. And although imaging and what we have discussed previously applies to this patient, I think clinical judgment is absolutely key. And what Dr. Hazel has done with the previous patient is to change completely the strategy. And instead of stenting left main LAD, he decided for precise stenting in order to make it simple and safe. I think this is the way to go for this patient too, is to try to make it as simple as possible and as fast as possible. And they would recommend to have a staged procedure, stent the coronary first, and take the patient back for the TAVR.
I agree. If she's having chest pain and EKG changes on the table, you need to stabilize the patient from the coronary perspective and as quickly as possible. And in those cases, I have a tendency to just do as quickly as possible a two-stent strategy in this type of a case and not really muck around too much. You could do something as, whatever you feel comfortable with doing as quickly as possible if she's unstable. So
Yes.
for the sake of time, if you could tell us what happened.
Yeah. So for just one comment, I usually decide which is causing the patient's symptoms. So I've had cases where I feel I need to do TAVR first. If somebody has critical aortic stenosis coming with pulmonary edema, I will go with the TAVR first, and then I worry about the PCI. But for me here, patient came because of his coronary disease. It did not present because of his severe aortic stenosis. The severe aortic stenosis just made my life more difficult, but I don't think this is the main presentation. All right, so I'll tell you what we did. All right, so of course it was difficult to cross. We had to use a microcatheter, and then I had to exchange for a rota wire. I decided to go with the rota up front because I did not want to waste time with like trying to balloon multiple times, doesn't open. So I decided to go directly with the upfront rotablator, and we went with a 175 burr. After a few packs, directly crossed, and then we didn't do a lot of runs. So this was good. Patient was having chest pain while doing the rotablation, but overall she was stable. And then what I did, this is the injection post. I decided not to do a rota to the circ because I did not want to lose my wire. And what I did, I started dilating. I did a left main to circ dilation with a 3015 balloon. Then I dilated the LAD with the same, or with a longer balloon with the 3020 NC balloon, and we see there's no waste, neither in the circumflex, neither in LAD. However, it was still difficult to put a stent, so I had to put a guide liner beyond the lesion, and then we were able to slide a 3.5 by 23 Zine stent. So we were able to stent across the circ. I was planning to go with the 2-stent strategy, but then I'll show you what I did. So we did left main to LAD stent. I did my first spot with the 4.012 at 18 atmosphere, and then did a second pot with a 4.512 balloon. So it was a 3.5 Zines. We went to 4.5, and then I did wire exchange. We made sure to try to be in the distal cell. And what I did then, I did a 2.0 by 12 balloon. And it's been something I've been doing a lot recently in most of my bifurcation. I avoid doing 2 stents. I went with the 3.520 DEB. And I went for short stents of 2:30 seconds instead of going for the full minute and let the patient breathe. And then I did final kissing inflation with 2.35 balloon, did a repot, and then this was the final injection. So I avoided to put another stent in the circ. This is also the cranial view, and this is the spider view. So what we then did, I brought her back a few weeks later, and we were able to do her TAVR safely. We rechecked the stents and the left main and the circ, everything was fine. And patient is now like a few months out, and she's doing excellent. And in my bifurcation cases, I've been doing, I don't know what's the experience of the panel, but I've been trying to avoid doing 2 stents if I can. And I've been using a lot of drug-eluting balloon, and we've had such good results, especially for large vessels, like when we're using for circumflex, like you see, you had a 99 ostial circumflex lesion, and we had a beautiful result with DEB.
Yes, I think the use of drug balloon is very good in this case for the circumflex, and it's very nice to finish the procedure as fast as possible. It's very nice.
Great case, Dr. Gamra, you have your
I would like to congratulate Dr. Savaya for this nice case. Of course, using DCB is certainly better than putting more metal in the coronary artery system. But now we need maybe more data to validate that approach. And we are doing like what you are doing, but we are awaiting data in order to be more comfortable with that approach. My question to you, was the DCB used in this case before or after the kissing?
I did it before the kissing. So I pre-dilated with the NC, did the DEB, and then I kissed with actually the DEB balloon. So I had another balloon, and I introduced the other balloon, the LED balloon, after I finished my DEB.
Yeah, go ahead.
I just have one comment regarding the DCB. I mean, the DCB, if it works, it's going to, or its benefit over a regular balloon, let's say, would be in reducing the chances of restenosis later. But you could have argued you'd have got the same result using a regular NC balloon 3.5, at least the same acute result. Because there's not going to be a difference between a regular balloon and a DCB acutely. If there's going to be a difference, it's in late outcomes. So and then the other question I have is passing a DCB through the struts of the stent. I mean, there's theoretically the consideration of stripping some of the coating off the balloon as it goes across struts. I mean, so that's another thing to think about, maybe.
I think also the best thing, as mentioned, Dr. Khalid, that using a non-compliant balloon before using DCP, because the DCP balloon is not a good balloon, but just for delivery of the drug. So I think you must prepare the case with NC balloon before and kissing before the DCP, and then at the end you can put the DCP with a non-compliant balloon on the other side to end the story.
Yeah, we're certainly taught, in the US still, it's extraordinarily expensive. So we do not pull out the DCB very often. But we are taught that for it to be the last thing that we use, so that's the drug delivery. And so that's nice that you kept at least the drug-eluting balloon in your KISS as well. There's a question in the chat regarding ROTA in an MI. And I think this gets back to the first question of, do we really think it's acute plaque rupture causing an MI versus just incredible, huge amount of atherosclerosis and some instability in the setting of just a large burden of atherosclerosis rather than actual plaque rupture with thrombus. What were your thoughts there, Dr. Saraf?
I think the use of following the algorithm for management of these calcium before using the ROTA is to test the balloon, because sometimes when you're using a balloon and you can inflate, so it's easy to go with a non-compliant balloon before doing ROTA, because the ROTA definitely in this scenario will increase more the slow flow, maybe the embolization. But the point is you need to test first with the balloon, but sometimes you cannot cross with a balloon. So the only option is to use ROTA.
Yeah, I mean, yes, if you look at the angio, it looked awfully calcified. Could I have worked with the balloon? Yes. I mean, I didn't want to have ROTA regret, so I decided to go up front. Could I have tried with the balloon and work? Yes, it worked in the circumflex, so it could have worked in the LAD. Yes. But I think by doing ROTA ablation at the distal left main, you also do some plaque modification on the ostium circ at the same time, that's why.
Yeah, and I agree. Okay. I mean, I think unless you're seeing, for me, for my practice, unless I'm seeing a large amount of thrombus, like obvious thrombus, visible thrombus, I have no problems doing rotational atherectomy.
So if there's a large amount of thrombus, one comment, the ostial circ is always very difficult to treat. And I think it's because of the shear stress and the torsion movement between the LAD and the circ. So I think DCB will be the treatment of choice for let's put it this way, not long lesions, but certainly ostial circ lesions. I think that will be the way to go in the future. And a lot of studies have come out, particularly from the European Bifurcation Club, supporting that concept. And I think this is a great choice here for you to do the ostial circ, because the outcomes between stenting and DCB may be very comparable, actually better with DCB if you look at some of the smaller registries coming out from Europe.
Yeah, I mean, we've had the DEB now for like more than 5-6 years. We've been using it. And if you had I mean, this patient is old, but having restenosis in the circ, and when you have two-stent technique in a left main, it always, you know, makes things more complicated. And then when they come for the second intervention, what are you gonna do? I think this, it doesn't mean that circ is not gonna restenose, but at least now I have the option to put one layer of stent. I'll do a tap on the next time. I thought this was just simpler.
Great. So Mirvat and Benita, can you just scroll to the question in chat to see if there's anything relevant we need to address with the audience?
I think we got through the last few questions. We were talking about TAVR, Impella, BAV, Rhoda. I think we got through most of it. These were fantastic cases. Thank you so much. These were great learning points and so many different ways of tackling these complex cases. So just a reminder that we're just putting all the data together and doing the best you can is really the most important thing.
Well, thank you very much to our colleagues in the Middle East, President Mirvat, for putting this together, and your talk, and Fadi and Ziad, whole time sake, putting on really great cases for discussion. And thank you very much for joining us on this Saturday morning. Hope this was useful it was good teaching experience for me, and hopefully for the audience to join. And thank you so much to SCAI for supporting this webinar. Thank you so much.
Thank you. Thank you very much.
Thank you.
Thank you very
Thank
much.
you.
Bye-bye.
Thank you, everyone.